Hello, everybody, and welcome to the latest in a series of NR Times roundtable discussions. And today we're focusing on a positive outlook for spinal patients. Thank you for joining us. We've got a fabulous group of panelists today who are going to share their experience and their insight and the reasons for optimism with reference to a positive outlook for spinal patients. I'm going to ask all of the panelists to introduce themselves and say a few words about their organisation, themselves, and their areas of specific focus. So, in no particular order, can I start with you, please, Rachel? Could you introduce yourself to those people that are watching?
Sure, thank you, Alistair. My name is Rachael Aram. I'm a partner at Irwin Mitchell, LLP, one of the, I suppose you'd say, one of the larger law firms in the country who deal with spinal cord injury. Personally, I chair the National Spinal Cord Injury Special Interest Group for Irwin Mitchell, and we also run conferences for professionals in relation to spinal cord injury and getting the cohort of practitioners together to share ideas and looking for more positive and creative outcomes for those with spinal cord injury.
Thank you for that, Rachel. Could I come to you next, Nick, please?
Good morning, I'm Nick Dougherty. I'm a lead physiotherapist for Elysium Healthcare. I'm based at the Bridge Care Centre in Middlesbrough, and we're part of the neurological division of Elysium because a lot of it is mental health and eating disorders. So we're a 12-unit across the country who deal with anything to do with brain injury, spinal cord injury. My area of expertise is spinal cord injury, including ventilation and respiratory. So we get all the ones from our local hospital, which is James Cook, which is our level 1 site. And then we basically treat and discharge back into the community, really.
Can move on to Barend, please.
Good day to you. My name is Barend to Haar. I've been involved in supplying equipment to people in wheelchairs for well over 30 years. And my interests have really been an international one. I've been involved with the international wheelchair standards and the wheelchair seating standards for the best part of 30 years. And I've also been involved with the British Healthcare Trades Association, where we try to bring together the commercially interested companies to look after the interests of various patient groups. The company that I've been associated with, and I'm pretty well supposedly retired these days, the more retired I am, the busier I get, but BES Healthcare has been involved in sourcing from around the world the best innovations that they can find that aren't currently available in the UK to try and make lives better for the people who have to use wheelchairs.
Thank you, Barend. If I could come to Stephen next from Thor.
Hello, my name's Stephen Ruffle. I'm the Commercial Director for Thor AssistiveTechnologies. We're a distributor of neuro rehab equipment. Been involved in both wheelchairs with Sunrise Medical and private provision for wheelchairs. In total now, almost 25 years in the industry. Mainly in the last 8-9 years, been solely working with exoskeletons and obviously spinal cord injured individuals. And then with Thor Assistive, we're expanding that range now into a range of neuro rehab equipment for all aspects of the body, and really focus on neuro rehabilitation, neuroplasticity, and bringing products into the UK from companies such as Foria Intelligence. We're the exclusive distributor in the UK for Foria. We're now working with Exotech and also the ExoAtlet device. So we're building up a range of options for people across the range from around the world.
Thanks, Stephen. And last but not least, although we will come back to Jon, Neil from Thor as well, please.
Hi, I'm Neil Shorthouse. I'm the Financial Director of Thor AssistiveTechnologies, working alongside Steve. I'm an engineer by trade. I've been an engineer for 30 years. We have another business, which is Thor Safety, which is an industrial robotic safety equipment supplier and safety manufacturer for industrial robots. I've had friends who are tetraplegic, paraplegic for the last 30 years, so I know the insight of what some of the problems they've been going through for the last 30 years. And then me and Steve have joined forces to obviously bring this new technology into the UK. So that's what we're doing at the moment.
Good morning, everybody. My name's Jon Graham. I'm the Clinical Director of Physiofunction, and we're one of the UK's leading independent providers of rehabilitation, outpatient-wise and community for neurology, complex trauma and chronic pain management. And as an individual, I've an unusual route to physiotherapy via an undergraduate degree in psychology and a master's degree in cognitive psychology. So that in combination with my undergraduate physio training gives quite a unique sort of toolbox to bring to the clinical situation. My personal interest is FES for the management of foot drop exoskeletons. So Steve and I have done a lot of work together over the years, and more recently with Neil. And over the last sort of my lockdown project was looking into EEG neurofeedback for the management of chronic pain. In addition to a clinical caseload and managing Physiofunction, I also founded the National Foot Drop Society, which sets up an annual foot drop awareness day each year, and to raise awareness of the condition and what can be done to assist people. And we've just celebrated our 5th National Awareness Day a couple of weeks ago. That's me.
Great, thanks, Jon. As we're with you, Jon, and we couldn't hear you for a little while, maybe I could start with you, and we will work through the panel. I'd be really interested in hearing your thoughts on what the big issues are, both opportunities and barriers, to really address the subject that we're addressing today, that positive outlook for spinal patients. So the big issues as you see them, positive and otherwise.
Okay, so sort of we look at this from a clinical point of view in two different ways, as a sort of what are the things that are negatively impacting on that positive outlook, and how can we influence those, and then what can we do to generate that positive outlook. So over 30 years of working with individuals with spinal cord injury, the majority of individuals often complain about the three P's. So I don't know whether we have a bleep facility on this webinar, but that's pain, pee, and poo. I would add an S into that for spasticity. So often those are the things, rather than per se the mobility aspects, that really affect kind of day-to-day living and drain that positivity. So as a clinical physio, there are our interventions are kind of limited for bladder and bowel, but we should have good relationships with referral relationships that we can send folk on. But with pain and spasticity, if those are where is our nut and bolts, and whether that's working with Steve and Neil at Thor and looking at how mobilizing an exoskeleton can reduce the spasticity, or as we've been doing more recently, looking at EEG headsets. Spookily enough, got one here, to allow people to manage their chronic neuropathic pain at home. For those in the audience that are going to Maskip this year, I'll be presenting a poster on how EEG can help individuals manage their neuropathic pain at home. So that's the two scales, is looking at what we can do on the things that are dragging positivity down, and then for the other aspect is looking at how we can boost positivity. So as coming from a sporting sort of background, my thing is to try and introduce people to the range of wheelchair wheelchair sports, be that connecting them with local rugby and basketball teams. And also we work and refer down to Access Adventures just near Heathrow, which is an amazing water sports charity helping wheelchair users do wakeboarding and water skiing. I'm also quite a keen baker, so I kind of, for those people that aren't, the sport's not their thing, let's get you in the kitchen, let's look at how we can do stuff there. And also we try and bring in friends and carers who've got some kind of crafting skills. I think it's trying to create another activity, another way of creating a new you. So I'm kind of drawn back to my psychology days in terms of Maslow's hierarchy of needs. So the folks are out of hospital, they've got those basic needs kind of covered, they're safe, they're fed, they're watered, and it's getting back up that hierarchy of needs to reconnecting with friends and family, getting new purpose in life, and finally the top of the Maslow, for those of you familiar with it, the self-actualization, the kind of, this is the kind of person that I want to be. So that's my peneth.
That's great, John. I'm sure we'll come back to some of those themes as the discussion progresses. Nick, can I come to you next and ask you to sort of address the same question, the big issues, positive and otherwise?
I think because we obviously are a private institute, I think sometimes when we are receiving patients from the NHS, obviously the financial barriers are some of our biggest issues, because we get only a short period of time to work our magic, because a lot of them are discharged to assess. So we receive the patient, we do our assessments, and we obviously start working towards our treatment goals and the residents or the patient's treatment goals. And then sometimes the ICBs and the funders tend to, with the purse strings, tighten them and move the resident on. And sometimes you in a short period of time, you can't maximize their potential to be able to, achieve the goals. And as like a clinical hands-on therapist, we always want to give everything back to let the patient reach the maximum potential. So I think our biggest barriers is financial. If you look at somebody who's has got a solicitor or a medical legal claim going on, that's a different entity really. They seem to get not a better outcome, but they've got a more optimistic outcome of the future, because financially they don't have that many constraints, and I think that's my biggest challenge. But as a team, we get some very good outcomes. So we, especially the high level C3 C4 spinal vented patients, we get some of them off the vents, and they always think that the physiology of the injury, the high level spinal patients, you think they would never get off because of the phrenic nerve involvement. But we do intensive weaning programs and intensive rehabilitation programs for the breathing. And I think that's a big goal for some patients, because having all this equipment associated with their injury as well, is quite weighing them down. So we look at them obviously holistically. And it's not just the condition we treat the lifestyle, we treat the resident or the patient, and we treat, everything else associated with it. So I think that there's pros and cons, but I think financial and constraints from a time perspective is one of our biggest barriers.
That's really helpful, Nick. And again, I'm sure we'll come back to talk about investment. Any thoughts on this ABI strategy that's been long awaited, that came out of this private members bill from Chris Bryant? That's due later this year, I understand.
Yeah, I mean, we're obviously we're part of a network where we're starting to get invited onto panels from the NHS and the longer term strategies. So it'll be interesting to see how they incorporate private and NHS, because I think at the end of the day, it doesn't matter what background you're from, it's all about the patient outcomes. So I think hopefully it might enlight the pathways in a more forgiving way, really. So I think let's see how it comes out. But we are getting invited onto more and more panels and our views are becoming, because at the end of the day we've all trained for a reason, and it's to give our worth back to the patient. So
Great,
I think
thanks,
let's
Nick.
just see how it reads.
Great, thanks for that, Nick. I'm going to come to Rachel next, but just before I do, Sam's just joined us from Morrello. Sam, we're just having a discussion about the big issues with reference to that positive outlook for brain injury care. Could you just maybe say a few words of introduction about yourself, and then we'll go round the rest of the panel and then come to you on that question of the big issues, Sam?
Well, hi, my name's Sam. I'm a clinical specialist spinal cord injury physio from Morrello Clinic in Newport. And I do apologise for being late to the webinar today. I was unable to join the link.
Great, thanks for that, Sam. We'll come back to you in a second when we've worked through some of the other panel members. Good to have you with us. Rachel, can I come to you next, please? And that question of the big issues.
Sure, absolutely. I think as a lawyer representing spinal cord injured clients, I see the majority of times one side. And I think I absolutely agree with what Nick was saying in terms of those barriers in relation to finance, because you do see that creation, unfortunately, of almost like a two-tier system because of the financial restraints. In terms of opportunities, you know, the fact of the matter is that over the last 25 years, and certainly, you know, the time that I've been dealing with clients with spinal cord injury, the landscape has changed so much, almost to, and this is a huge opportunity because the potential for it to grow even further, and you know, we're already looking at AI involved in pathways and various things. I mean, it's only recently, obviously, we have the exoskeletons, the mobile suits with spasticity, you know, various other things. But I almost feel like, in terms of an opportunity and barrier, going back to basics, I don't think patients generally get enough time in specially designated spinal cord injury units. For example, there isn't one attached to every MTC in the country. There are very limited beds, and we have an amazing cohort of professionals who are trying to do their very best for these patients in very limited circumstances at times. Now, that may or may not change the outcome physically, but for me, and certainly my observations, I think, and this is where the opportunity lies, we need to get the adjustment to injury right, because, and while I accept adjustment deals with a number of different factors, adjustment's also been shown, obviously, to link to various other outcomes, including, you know, morbidity, mortality, healthcare, quality of life. And I think the more we can invest in patients being able to adjust their mental health, investment in psychological support when they are first injured, and going through that pathway and having a clear pathway for them, because it is a bit of a postcode lottery, for me, then leads the way, incorporating obviously the good pain management, bladder and bowel management, sexual relations. It all builds that cohort of resistance that I think, you know, our spinal cord injured patients would really benefit from in the future, whether they are purely relying on NHS and ICBs, or whether there are private pathways for them and how they integrate. So it's almost, for me, going back to the beginning.
Thanks for that, Rachel. Barend, the big opportunities and barriers as you see them?
I think the opportunities that I'm seeing is that over the years there has been a better understanding that a wheelchair is not just a item that's got 4 wheels on the corner. It is actually, for many spinal injured people, an orthotic, an orthosis. It's something that gives them the means to give back some of the functionality they lost by losing their legs. And my challenges over the year have been seeing wheelchair designs that have been created by engineers in ivory towers without actually realizing what the equipment on the wheelchair is there for and the safety issues. And that's why I've been heavily involved with the wheelchair seating standards, because there are practices that are unsafe and have been unsafe. The major concern that most people have is where to put a positioning belt. And most people, when they get in their car or their aircraft seat, put something across their waist. And that's a restraint to stop you from flying out of your seat in turbulence or whatever. Whereas the belt that's on a wheelchair is there for positioning and for good anatomical movement. You need to have it in the right position. And so often it is in the wrong position. So there's one of the standards that tells people how to select the belts and where to put them and so forth, for safety reasons and for functionality. There are other areas where, for example, flammability around wheelchairs has been based on furnishing standards, and the risks of fire for somebody in a wheelchair are very different from somebody who's living in a building. And that's one of the achievements we've had over the years, is simplified things. We've moved away from using cigarette tests because we discovered that cigarettes were not standard. In a packet of cigarettes, you can get a 400% variation in the amount of heat that comes out of the cigarettes. So a nickel chromium coil heating system, much easier to use, much safer to use, that's been evolved. So a lot of the safety side has been moved on, but actually where the equipment goes and what it is on the wheelchair has needed a lot of progress. And a couple of things I've seen come out in the last, in just this year, have come from a physiotherapist in Belgium, a guy called Bart van der Heyden. And one of the things that we've seen on a wheelchair, for example, is that most of the armrests really are a bit of metal that is there maybe to stop you from moving sideways out of your seat, but it does nothing for your upper extremities. And we get a lot of people with subluxed shoulder joints and a lot of pain in the shoulder joints. It's really because their upper arm is not being properly supported. And the new devices have come onto the market that actually position your arms in an anatomically correct position. And another invention, again from Bart van der Heyden, is that when we look at our backs, we don't call it a backrest any longer on a wheelchair, it's a back support because it's functional. And moving the terminology from rest to support makes people think a bit more about what the equipment's doing for them. And Bart's latest design, his Epic thing, separates the movement of the upper back from the lower back when you recline a seat, and removing all the shear effects on people's clothing and on their skin underneath. So there are things still coming out that can apply to wheelchairs that make them work better for the individual, working with their anatomy as their anatomy is designed to work, and not as the engineer in an ivory tower wants it to work. So that's my little hobby horse for today. But get the equipment, getting the right equipment to do the right job, and getting people trained. And that's a big challenge, is people up to date of how to make use of the right equipment. Therapists in their courses for their degrees are lucky if they get more than one session on seating. And seating is a really complex area, as is walking. That's my hobby horse for today.
Great. Thanks, Barend. Really interesting and helpful. Stephen, if I could come to you next, and then Neil to talk about.
I've got a couple of points. Just to follow on from what Barend was just saying. I remember doing prescriptions for wheelchairs where I was introduced to somebody saying this person needs a power chair, and actually they were positioned so badly in their manual wheelchair it meant that it was impossible for them to propel. Whereas if you get them in the right equipment and you get them positioned correctly, then you can get the exact results that person needs to give them a more positive outlook and be more in control of their wheelchairs. But I also remember being told, well, we asked you to, how much is that wheelchair? And you might say, well, it's £2,000. It's a very prescriptive wheelchair. Well, it was at the time. and then they say, well, yeah, but we asked you to come here to do a power chair assessment, so we can't afford that really expensive manual wheelchair. But they were willing to spend £4,000 on a powered wheelchair, so which didn't position them any better. So yeah, I'd really echo Barend's comments on obviously getting the correct specialist and getting the right equipment. It's no good having excellent equipment if people don't know how to use it. That's seen so many times, and that's why you tend to end up with a lot of lovely equipment that's being used as a hobby horse in the corner, not being used correctly. Obviously, the second point I was going to make is that we obviously introduced rehabilitation equipment for various types of injuries and conditions, but again, going back to a little bit what Rachel was saying regarding time, one thing that we are conscious of is that if people can use the right equipment early enough in their journey and get more repetitions, they can get more activity at those early stages. Getting access to the equipment is obviously the issue. So we can add another P to John's list, and that's obviously price. So, we're trying to look at it in a slightly different way. We're trying to work in partnership with some of the better and more forward-looking groups in the country, working with them in partnership to try and make the equipment more accessible, starting to rent equipment rather than having to look at a massive outlay. And then also, when you're looking at something like rental, then that means that things can stay up to date. They can be replaced. They don't have to be set in stone and then obsolete in a number of years' time. So, we're trying to look at that from an accessibility of equipment point of view, because we can see there's many studies that show that this equipment does have a really positive effect. We do see really positive outcomes, but obviously not enough people have access to it. So, and again, going back to if somebody's going through a personal injury claim, that tends to be a much smoother journey. You can see the results for yourself. The evidence is there. But obviously, if they don't have that ability, and when we're talking about a massive population such as stroke, for example, then that becomes a real issue. Good when you know that there is equipment there that can really help.
Thanks, Stephen. Neil, would you like to add anything to that?
Yeah, more so for me, it's on a personal level because of having friends who are spinal cord injury patients for 30 years. I've actually been out on the lash. We've been away. I've seen what they've had to face, and it's not just the physical side; it's more so the mental side. I don't think there's enough out there. It's great having clinics like Physiofunction who've got the exoskeletons, and there's a few clinics around now which are embracing technology to get a better outcome early on in the patient's injuries. But I think it's afterwards. Having exoskeletons for private patients is brilliant. They're getting more accessible now. Like Stephen said, we're actually now we're doing a medical contract plan. So we've got a finance company we work with, so private patients can actually have it through finance, so they don't have to outlay a lot of money. We're actually looking at setting up. This is going to be a bit of a long-term plan, but a bit like a fitness first type gym scenario, where it's not a clinic, it's not where we've got physios and everything else. It's a bit of a centre where people can come together, they can talk, they can chat, they can have a coffee, they can have a cake, whatever they desire, but to actually give them the opportunity to use some of the latest equipment as well in a gym type setup. These are going to be small areas. It's going to be a working showroom for Thor Assistive, but it's also going to be there. So especially with my friends, where they can just go and chat to people about what they're faced with on an everyday basis, which sometimes they don't want to talk to. I remember having a conversation about manual, and the weeing and the pooing and stuff like that with one of my mates, and he felt very embarrassed to speak to me about it. And I said, well, don't be embarrassed about it. This is something that you have to go through. But I didn't know at the time. As a 24-year-old at the time, I was a bit horrified what he actually had to go through. So for me, partnering up with Steve and Thor Assistive and working alongside people like Jon and other clinics out there, which we work closely with, it's great to have that when they first got this injury and ongoing, but then it's the after effects afterwards. Let's not let them not be forgotten and think that they've been through so much rehab, they're okay now. I think they need rehab for the rest of their life, and they need a space, a social space, where they can just take out a bit of frustration and speak to people about what they're going through and what they're faced with, and give them accessibility to some of the latest equipment out there. And the more equipment we can get into the UK, the cheaper we can make it. So we're signing deals with Physio at the moment where we're actually buying nearly £400,000 worth of equipment ourselves. We've actually purchased it ourselves. And we're trying to set up these centre of excellences with clinics, and that will give them big discounts to be able to get them this equipment into their centres. So there's quite a lot happening over the next 12 months with Thor Assistive and the way we're trying to push technology, and then afterwards, So that's what I'm passionate about more than anything is the aftercare, more so than anything.
Thanks, Neil. It would be easy to ignore that. I think that's such an important point, the need for that emotional and social support on a sustained basis, as well as the technology and the treatment.
I think one of the problems one of my friends had is a paraplegic. He was ill-advised 25 years ago about what his rehabilitation should be when he gets home. So they said he should have a multi-gym, he should be using a standing frame. Now his shoulders are absolutely gone. He's going to have operations on his shoulders because he overdid it. He overworked himself. He thought he had to compensate his upper strength for the loss of his legs, which has now caused him major problems. He hasn't been away for 10 years. He's in a massive amount of pain all the time until he can get this operation, which then there's complications to the operation with that anyway. So he's going to be more housebound because he won't be able to push himself in the chair. And the psychological side is that he's still up there mentally. He's still the same person that he was when he was riding a motorbike and being a bit of a lad, a Birmingham City supporter back in the day. He's still exactly the same person mentally. He doesn't have cognitive problems. He has mental issues because he's in a wheelchair. So I think it's all hand in hand, making sure they get the aftercare as well as the care that they have at the beginning.
Yeah, thanks, Neil. Sam, if I could come to you again to address what you think the big opportunities and the barriers are with reference to the subject matter we're discussing.
Well, I would echo what some of the previous speakers have said, really. I was lucky enough to have worked in the Welsh Spinal Cord Injury Rehab Centre for many years before coming to work in Morrello, where I've worked for 5 years now. And working in a private clinic such as Morrello, we're lucky to have a lot of new technology to try out, and the benefits of those have been discussed previously in this discussion, and it's excellent to have access to that, but it can be cost prohibitive for some clients, and we try and make that as affordable as possible by looking at the packages that we offer and renting out equipment. But also on the other side, having worked in the spinal unit before and now here, I think it's opened my eyes to the number of individuals that have never been able to access the spinal cord, the specialist centres, and the importance of that, because as Rachel said, there isn't the access to the psychological care, the bladder and bowel care, the peer support, and the impact that has on people is often more profound than their physical difficulties. So I mean, it can be quite useful. Having worked in the spinal unit before, I know how to refer people in, but I think there's a lot of people in the community that aren't aware of what's available to them and how to access that. And I think that's quite a scary thought. It's the holistic approach that's needed, not just the therapy, physical side of things.
Thanks, Sam. I'd quite like to open up the discussion based around access, diagnosis, and making sure there is equality of access and awareness of all those things that are available, so that people that require treatment and support are getting the right diagnosis, the right support, and that is universally available. Jon, can I maybe come to you to address that, and then we'll open it up for other panelists that might want to contribute to that discussion about access and diagnosis?
Oh, can I get lost on that one? That's a big old question. That it's been really very interesting to hear from my fellow panel members. Yeah, and as we kind of said, there is this. I mean, I think statistically, Rachel might be able to back me up. I think what is it? 1 in 4 individuals, their spinal injury has got some kind of compensation attached to it, which means 75% of individuals are having to cope without any backup from people like Rachel. And I know from personal experience doing med legals for Irwin Mitchell and Stuart, just how well these guys battle for their clients, and the difference that in the mental health of these individuals to get that the right care, the right housing, the right support, what difference that kind of makes. We've always, as a company, tried to work as close as I can with my NHS colleagues to kind of say, do a bit of a show and tell. Come and look what we've got here. Come and, is this something that you think would benefit some of your clients? And looking at how for some of these things you can get them seen by a supportive GP as for an independent sort of extraordinary funding, because when enough of those things happen as an extraordinary, then the NHS potentially can start to take notice and think, hang on a minute, this is no longer extraordinary. What is the benefits? Can we get this as a commissioned service? So I remember back in the sort of 25 to 2010, we got involved very early doors in the Saberflex, for example, which is a hand rehabilitation device primarily aimed at stroke patients, but used very successfully by a number of individuals recovering from their spinal cord. And that was predominantly and only available in the private sector, but gradually by people like myself and other physios and OTs that were training in it, introducing it through in-service training to colleagues in the NHS, that eventually became adopted as a standard of care in many NHS institutions. So it's kind of combining awareness and access. If we can work closely with our NHS colleagues, making them aware of some of the rehabilitation technologies, and help them look at getting those taken on as commissioned services.
Thanks, Jon. Rachel, I think you wanted to come in there.
It was simply to back up Jon's comment about, obviously, the small number actually of those people who sustain a spinal cord injury are as a result of trauma, and when therefore it may result in a claim. But I think just picking up on the other point in the original question, if I may, I think at the heart of this, in terms of accessibility, which is obviously one of the points that you'd raised, the difficulty is now that obviously the systems have slightly reorganised and we have these designated major trauma centres across the country, which are doing an amazing job in very difficult circumstances. The difficulty we then have is that every patient's pathway could be slightly different. and I agree with what Sam was saying earlier, in that not all of them do then have access to specialist spinal cord injury units. And, you know, it may result, for example, in more commonly those patients who don't perhaps get that specialist knowledge and end up, as Neil was saying about his friend, you know, being given the wrong advice about what they need to focus on when they are discharged. And the difficulty with that as well is that, unfortunately, with the discharge coordinators at each of those units under an awful lot of pressure, that some of the pathways then back into the community for those patients can be very varied. And so looking at the right equipment, the right care support, bladder, bowel management, pain management, psychological support, it all flows from there. So we have to really get it right at the beginning for all of these patients, whether they have a claim or not, in order to really support in the best way we can. I absolutely agree that there needs to be more collaboration between private and NHS, and however we can do that is, you know, a really positive thing in my book. I don't want to be all doom and gloom, but we need to get the pathway right.
Would anybody else like to come in on that question of diagnosis and access? Stephen?
Yeah, I was just going to say, I remember when I first started with Rewalk and trying to introduce exoskeletons to the UK, it was, if you look at the sort of dozen spinal cord injuries that are around the UK, I know I've worked with Jon, we've done a couple of joint presentations and in-service training with certain pieces of equipment. I know we did a few down at Salisbury, and so some places are starting to be open to it. But I tend to find that the majority are quite resistive. And I remember doing a couple of presentations at some spinal injury units and almost sort of sneaked in the back door so that I could show the professionals, but so that the patients didn't see what we were offering. And I think there's obviously an issue there with that, almost a perception of keeping people, they have to get used to their wheelchair life and almost not give them these opportunities or even just information of what could possibly go forward in the future. It tends to be more of a keep it away from them because they have to adjust to this new life, which I always thought was quite a strange perspective. And I think that's where you sometimes see that the prospectual sort of difference between when you work with the private sector and when you work with NHS, and getting them to work together is absolutely vital, I think, to bring the knowledge to the patients, knowledge to the healthcare professionals, and so that they can all start moving in the same direction, because it does seem to be they tend to be in opposing directions quite often.
Thanks, Stephen. Barend?
Working on some of the points brought up there, one of the areas for people in the spinal injury units is often they have a very good support network of people who've been previously through all the traumas that the newcomers are finding. But I think often the problem is once they leave that unit, they leave that support background and become a bit more isolated. However, the SIA does have, I think, further support available, but not everybody's always aware of it. I think one of the challenges of what equipment is needed is that I've seen that there will be a degree of assessment will go on the spinal injury clinic, but the local wheelchair service where that person lives has to provide the equipment. So their local restrictions on what they provide is what they get. And they may end up with a wheelchair, but there's a lot of research that shows that if you can get an hour a day standing, there's a heck of a lot of benefit to your bones, to your whole metabolism, everything that goes on inside your torso. All our physiological functions are in there, and having it squeezed up in a seating position isn't great for those. So the benefits of standing for an hour, as long as you don't overdo some of the things that were mentioned a moment ago, is that your whole function in life is a lot better. But where does somebody get pointed to get the standing equipment alongside their wheelchair equipment? Because the wheelchair services won't be providing that. So the channel of getting, for the people going through the NHS, of getting the right equipment is quite a challenging one, and people not being aware necessarily of how important some of that equipment could be.
Yeah, thanks, Barend. Nick, I think you'd like to come in.
I think just obviously following on from what Barend's just said, I think sometimes the aftercare can be, some of the biggest barriers. I think the acute and critical care from initial injury is fabulous from the NHS. I think as soon as they leave the spinal unit and come to external rehabilitation or even home, I think reaccessing it can actually be a massive challenge. Some of the higher level spinal injured patients who have the severe consequences of spinal cord injury like autonomic dysreflexia, they tend to be able to access the unit quite quickly because it's quite it can be a really life limiting condition. But say if, for instance, like neuropathic pain from spinal injury or pain, as I say, pain management or spasticity, getting re-referred back into the service can take sometimes months, and the compensations that develop from these manifestations from spinal cord injury can be challenging as a treatment therapist, because you've got to try and tick them over until they're actually assessed by the specialist back in the acute sector. So that's some of the challenges we find, is we've got to go through a process of assessment, re-referral, and waiting for the interventions to occur. And sometimes, that can have a massive impact upon psychology, their mood, which makes rehabilitation a massive challenge when it comes to, progression and maximizing potential.
Thanks for that, Nick. Sam, I think one or two of the speakers have touched on the need for investment across all the areas that we've covered. Is awareness pushing all those that fund these services to make sure that the money is there to support the treatment that people require, or does that still represent a significant barrier?
That's $1 million question, isn't it? I think the awareness is there. It's just the whole pathway needs to be looked at, and how that's funded. And going back to what the previous speaker said about accessing outpatient service, in our local spinal injuries unit, there are 2 consultants for inpatients and outpatients, and outpatients are kept on the books lifelong. So at some point that system's going to break. So where the funding goes into that pathway is the big issue. Does it go in at the acute end? Does it go in at outpatients? Or does somebody need to look at the entire pathway again from the beginning and revamp it completely? Because it's always going to be top heavy if patients are never discharged. And then they will have to prioritise those patients that are most at need. But then everybody has a need. It's just some are more urgent than others. So it's mind-boggling how that's going to be sorted out. But I do think it needs to be multi-sector, looking at the entire pathway from injury to living with spinal cord injury in the community, from a private and an NHS point of view.
Does anybody want to address that question about whether or not there is a more sensible and structured way to target where the money goes, or indeed the sort of corollary to that, which is how you actually have services that are more joined up and more holistic, including those provided by the private sector and the public sector? Stephen.
Yeah, I was just going to say, I think going back to what I was saying about access to standing and maybe exoskeletons, or at least decent standing frames in the early stages into admission into a spinal cord injury, that always to me seemed to make an awful lot of sense, because if you get people into that habit of standing, and we all know the benefits both for standing and walking, you know, internally, mentally, right across the board. I think we've all heard that, well, you should stand 3 times a week, and that's how somebody generally leaves when they get discharged. But I think if they were encouraged at that earlier stage to do more of that exercise, it would become more of a way of life, and they probably concentrate an awful lot more on getting people the wheelchair skills and everything else they have to do to be discharged, but not necessarily how to look after themselves long term. I think you're muted, Alistair. Sorry.
Thanks for that, Stephen. I was just checking that everybody was paying attention. I wish. I'm going to bring Sam back in quickly because I think you wanted to respond to that, Sam, and then I'll bring in Neil and Barend. Sam.
I was just going to talk about the stand-in actually, and having worked in both areas, pushing the stand-in 3 times a week for 40 to 60 minutes was what we used to tell everybody. The number of people that came back to outpatients that said they no longer stood was a lot higher than those that continued standing. But that said, with the new technology and making standing more functional, I think that improves compliance, if you want to call it that, with continuing standing when they're discharged from the units. If it's more functional, then it's going to be far more interesting than standing in a wooden standing frame in the corner of the room, which has also probably got your clothes drying on it because it takes up so much space. So yeah, with new equipment that's available and making that standing regime useful, functional, I think that's going to improve compliance over time.
Thanks,
That's
Sam.
all I was going to add.
No, that's really helpful. Thank you, Sam. Neil.
Yeah, I just wanted to reiterate on the standing as well. You know, we've been working closely with neural pathways and steps alongside Jon with exoskeletons, but lately with the new Fourier Exomotus M4 standing frame, and some of the results we've had from that has been absolutely amazing. Just the fact that they're not just standing, they're actually standing and walking either on air or across the ground. It's in a frame, but the stretch that they're feeling, the burn, and the feeling that they're actually walking again, unaided, because they're actually in a support frame. And a few weeks ago, we actually had a lady in the Exomotus walking alongside her husband in the clinic hand in hand, which they hadn't done for years, you know, and stuff like that. It's just the mental aspect of that is absolutely superb. So not only are they getting the benefits from being in an exoskeleton, but the fact that they can do stuff which they didn't think they were ever going to do again. It is important. I think trying to get the NHS to realise that there is centres out there like Physiofunction, like Steps, like Neural Pathways, like Morrello. They need to actually utilise these companies a lot more. They need to look at the patient, and that's the person that's important at the end of the day, looking at what injuries they've sustained and which is the best way forward for them to actually go, you know, and utilise what's actually out there. It will take a lot of pressure off the NHS. Okay, there's a funding to that, but the NHS itself isn't relatively cheap anyway. So they've got to start utilising more and more. I think Jon's been working alongside the NHS quite a bit, but they've got to start looking at, let's use these clinics a lot more to take so it's not so top heavy, and it gives the patients the best of the ability that for their outcome, you know. So that's it.
Thanks for that, Neil. Barend.
For the research I've been reading through, it really recommends not 3 times a week standing, but an hour every day. But that's the ideal, and getting to the habit and having the tools that you can actually do something useful while you're standing makes it not just a chore, it's something that's functionally beneficial. I think in the kind of markets that some of the people on this panel have been talking about, it was interesting at Rare Care a month ago how many new exoskeleton devices are coming onto the market. Used to be maybe one, maybe two booths showing that, but this time there must have been over half a dozen different solutions in that direction, which is this webinar is about the outlook for spinal patients. And that, I think, is a positive trend if more money being invested. And modern technology, manufacturing technologies are bringing the costs down as well, and that's been a barrier. On the cost front of things, the NHS patient has access to personal wheelchair budgets and so forth, and those can be topped up by the individual, but very few of the NHS services really understand it, and they don't want to confuse their picture by people putting some of the money from their own pocket alongside what they really pay for through their taxes. So that's another area where the outlook is potentially better, but I'm not sure how much it's being exploited. And a final point, well, I've got the screen, is that you talked about the enjoyment somebody have had of walking alongside. And I've got in the company I'm associated with, we had an intern who's was working on a project of how could you push a wheelchair walking alongside the user rather than somebody behind. And it's much easier to communicate when you can talk side by side as you're walking along, and also the whole dignity is a lot better. So that is an idea that is being worked on in the background. So we're talking about outlooks, and there's something that might be worthwhile for some people.
Thank you for that, Barend. As we sort of draw towards the end of our discussion, and I think we could go on for an awful lot longer, and I'm sure there'll be supplementary discussions to focus in on some of the areas we touched on. I'd just like to ask each of the panelists to say a few words in summary. But before I do that, can I just ask the panelists if there are any areas that we haven't covered that anybody would particularly like to address? Okay. We have covered a lot of ground, from investment, access, technology. Neil, the points you made about the need for psychological, emotional and social support as well. So I'm just going to ask each of the panelists to say a few words in summary about the big things. If there were one or two big things that you would like to see change or improve, or areas where you think there's a particular emphasis now that will give people hope and that positive outlook for the future of care in this area, what would those things be? Big priorities, things you'd really like to see pushed. And if I could maybe come to you first, Neil, on that.
Okay, yeah, thank you. Yeah, I think it's been really useful today listening to what people have got to speak about with spinal injuries. One point I would like to make is one of my friends was a wheelchair rugby player, so he was in the wheelchair Olympic team. He did four seasons or 4 Olympic games. That actually gave him a lot of purpose to life. The fact that he was in a team, bonding with a lot of people at Stoke Mandeville and training sessions in Halzowen. I did find that in the early days, their funding wasn't very good. They had to self-fund a lot of these trips themselves, which I think is disgraceful, but I think that's now been addressed. I think there's lottery funding and stuff like that available now to the accessibility of wheelchair sports. And I think that just needs to be pushed more and more. People are in wheelchairs that, some people, you look at wheelchairs, you think there's got cognitive issues as well as, but they're just normal people who have broke their backs or their necks and they just can't walk. I think they need to be spoken to and looked at as normal people, because that's one thing we found really stressful is that they used to talk down to my friend and are you okay? And are you this? And he's like, look, I'm fine. I just can't walk. I can't bloody walk. And after a few more beers, it was a bit more verbal than that. So, but yeah, I think just making sure that it's highlighted even more that there is help out there. We did a conference lately with Hannah Cockcroft, who was inspirational as well, and she spoke about some of the lifelong ambitions that she achieved through wheelchair sports. So yeah, it's just making sure we can make sure that's highlighted a lot more in the media, and also with the local councils and the government need to be pushing that a lot more, because there's a hell of a lot of disabled wheelchair users, spinal cord patients out there in the world today. So that's it.
Excellent. Thank you, Neil. Rachel, could I ask you to just articulate your sense of the big priority for a more positive outlook?
Yes, I think it's been invaluable listening to everybody today. I think for me, the two main issues for takeaway and for further investment and work to create those opportunities really are to have the clear pathway from accessibility at the specialised units right the way through to discharge into the community, and appropriate follow-up. And the second point really for me, which I think is absolutely essential, is that working together between those who are in private practice and have that accessibility with NHS treating individuals. I know that BSRM did a protocol, I think it might be as far back as 2015 or slightly further, looking at a protocol to do exactly that. And I remember when I was trying to talk to some individuals within the NHS, no one had ever heard about it. And I think the only people that will truly benefit from that, which is the positive outcome in all of this, is the patient. So I think if we can get back to looking at that and the right mechanism to allow that to happen, I think it would be much more beneficial for spinal cord injured patients.
Excellent. Thanks, Rachel. Barend, same question to you. Big priorities for a positive future.
For what I've seen over the years is there has been a development of technology that can assist to substitute for the abilities that have been lost. And looking around the screen, nearly everybody's got visual aids, and everybody accepts for normal that we have visual aids, and that's technology to some extent in there. And we have new materials in the lenses in our glasses and so forth that make them lighter and better for us. And I feel that the professionals really need to be given enough time to bring themselves up to date with what is available and how best to use it. And anything I can do to help anybody in that respect, I'm more than happy for anybody to contact me. But there are the standards out there for safety issues. Make sure equipment that's supplied has been tested to the standards and not that's anything off the back of a bus.
Great, thank you, Barend. Same question, Nick?
Yeah, I think I'm very much on the same page as Rachel. I think definitely less barriers between private sector and NHS. I think innovation can be the key to giving quality of life back to spinal cord patients. And I think sometimes the constraints and barriers in the NHS for ethics and going through funding and this, that, and the other can actually be detrimental. And I think sometimes in private practice, you've got less barriers. And I think that can be a key to enhancing the pathway for outcomes, really. So I just think that, less barriers and more communication.
Thank you, Nick. Stephen, final thoughts?
Yeah, a couple really. First one really refers back to what Rachel was saying. I think that good practice right at the beginning of the injury, and then better follow-up and possibly more social interaction afterwards. Going back to what Neil was saying as well, we're thinking about these sort of social spaces because I think a lot of reason people end up maybe getting into sports is because of the club aspect of that. They don't necessarily, the sport isn't necessarily the focus, it's the fact that they're with like-minded individuals who are looking for a social outcome. So I think that is important for a longer positivity going forwards. And yeah, just, I mean, obviously we're interested in supplying technology, but I think getting that technology in the early stages and getting the awareness up, you know, even with some of the trials and some of the people that use our equipment, they do refer back to the manufacturers. We have a really good relationship with a couple of the clinics, giving feedback back to, say, Fourier Intelligence, so they work with them. They have regular video calls on the outcomes, possible improvements to the equipment. And then we're just about to start putting some more editorial into the NR Times, for example, just so that some of that information can be shared further afield. So information, awareness, they're all barriers to somebody early injured, I think. And, you know, they're thrown into a new world that they don't know very little about. And I suppose it's all of our responsibility to make them aware of what opportunities there.
Great, thank you, Stephen. Sam, big priorities for you?
Again, I'd agree with the previous speakers. I think one of the major things is improving equity of access to the spinal cord injury units and specialists, whether that's as an inpatient or an outpatient, but access to those professionals in that service. And the other is improving awareness of the technology and the innovations that are available, improving that awareness to everybody, and then working out how more people can access that and more people can access the specialist rehabilitation that we've got in our various clinics and the technology that we're offering, not just those people with personal injury claims and the finances, making that more accessible for as many people as possible, really.
Excellent, thank you, Sam. And Jon, you get the final word on your big priorities, final thoughts.
So I echo a lot of what's previously been said. I think Nick's kind of highlights one of the really important things about there being less barriers in private practice. That it's not even about the financial barrier. It's just, if I see something, if Steve or Neil finds something interesting, they'll pick a phone up and go, Jon, do you want to have a look at this? Do you want can we bring it down? This is the kind of client it will help for. Can they would they be willing to have a go? So we've not got to worry. We can actually get the technology to an individual very, very quickly. And so that on the back of that, it's again highlighting this. It would be great to see more active collaboration between the private and the public sector, simply because we are looking at these things, not on a daily basis, but we've got access to it. And we just want to share, we're more than happy to share this stuff. And if by reaching out to us and being aware these things are available and what our real warts and all opinion of it is, you're in a better position to make your own patients raise their awareness of it. And then finally, I'd kind of go back to my old life as a psychologist and say, if I want a service I'd like to see being developed is almost like a life coach for people following their discharge to help. I mean, I'm a big fan of Maslow's work. A lot of people post-injury are on a new journey. They had a destination. I was going to do this. That's the kind of person I imagine I would be in my 40s or 50s. That still for many people is possibly the routes kind of changed a little bit. So I would like to see life coaching introduced as a kind of longer term post-discharge support for individuals with spinal cord injury.
Thank you, Jon. I think that's a really positive note in which to conclude this discussion. On behalf of NR Times, I'd just like to thank all of our panellists who've been fabulous for being so generous with their time and experience and insight. For all those that are watching this, thank you for doing so. This discussion deserves to be heard and seen by as many people as possible. So if you're watching this, please share it as widely as possible. And indeed, if you've got any feedback or thoughts or comments, fire them back through to the NR Times platform. So thank you for all those that are watching. A really big thank you to our fabulous panelists today. And I'm sure we'll revisit some of these themes on the NR Times platform and possibly in future discussions as well. Thank you.
Thank you.
Thank you very much.
Thanks.